Okay, sorry about the dog in the background. I'm recording this at home. We're going to talk now about assessing the urinary system. When you're assessing your intake and output, we would need to assess intake and output really carefully for patients who have either renal or cardiac disorders. We also want to assess any patient at risk for fluid overload or any patient at risk for dehydration. So when we're assessing intake and output, we want to make sure that we're catching all of the urine first of all. So use the toilet collection container, use the urinal, have the patient use a bedside commode with a collection container. Whatever you do, make sure that you tell the patient you need to collect that urine. Quite frequently, I see nurses assume that the patient knows we need to measure their urine when they may not. Urine should be measured in a hard container. So if they have a Foley catheter, that drainage bag is soft-sided, so you can move the level of fluid just by changing the shape of the bag. So that's not an adequate measure. You need to empty it into a hard-sided container so that it can be measured. If a patient needs hourly I&O and they have a Foley, we actually can use a Foley with a urimeter, which is a hard container on the front of that Foley bag. And that allows us to check their output hourly without opening the system. And then that urimeter can be dumped into the main bag. A patient who has less than 30 milliliters of urine output from an hour for more than 2 hours usually is not getting adequate renal perfusion. Urinary output is an important measure for renal perfusion. Okay, so it's a really important measure for perfusion. So if our patient is septic and we're monitoring their urine output, we need to see adequate output. If we don't, that's an indicator they're not perfusing, right? So whatever's going on with our patient, look for urine output. And 30 milliliters is kind of the magic number. We want 30 or more. We need to assess for signs of UTI. Patients may have frequency, urgency, burning, foul-smelling urine, cloudy urine, or sediment. Sometimes patients who are pregnant or who are older do not have some of those symptoms. They may not have the burning or pain. They may have, if they have frequency and urgency all the time, they may not notice the difference when they have a UTI. There's some diagnostic tests that are done. There are some diagnostic tests that are done to evaluate urinary health. A UA needs to be caught in a clean container. If we are collecting a urine specimen from a patient who voids, we need to teach them how to do a clean catch midstream collection. So they need to use some sort of cleansing wipes or some sort of cleanser to clean around the urethra. They need to begin urinating and then try to stop the flow and catch midstream so that we're catching the bacteria that are in the urine and not on the outside of the skin. And that's important just for a UA. It's even more important for a urinary culture. If a UA looks as if there's infection, then it should be cultured. In a lot of facilities, that triggers an automatic order to culture it. If we're collecting a specimen from a catheter, the only time you can ever collect a specimen from the catheter bag is when you first insert that catheter. Anytime after that, you have to use the collection port. 24-hour urine collection. When you're doing a 24-hour urine collection, you need to make sure you're giving your patient very good education. Again, because we want every bit of urine that's produced in a 24-hour span. So we have them urinate at the beginning of this and discard that urine, and that's the time beginning. So if we're going to have them start this at 9 in the morning, we have them urinate at 9 a.m., start our time then, and then collect all of the urine between 9 a.m. and 9 a.m. the next day. At the 24-hour mark, we want to have them try to void again to see if there's any more urine. And then we collect all of it, seal it, label, and transport to lab. During that 24 hours while they're collecting urine, the container needs to be kept chilled. So we usually keep it in a basin of ice, just a bath basin with some ice, have them catch their urine in in a hat in the toilet container and dump it in each time. A blood test we might do, or some blood tests we might do, are BUN and creatinine. There are measures of renal function. An ultrasound might be used. We actually have bedside bladder scanners that use ultrasound technology to evaluate urinary retention. We might x-ray the kidneys, ureters, and bladder, KUB, for position, size, structure, and perfusion. I'm sorry, that doesn't evaluate perfusion. That's an x-ray. Okay, so, and what can an x-ray show us? It can show us position, size, structure. Okay, now if we're looking at perfusion, now we're talking about a pyelogram. An intravenous pyelogram is an IVP. A contrast medium is injected, and then x-ray is used to evaluate perfusion. So if someone has a shellfish allergy, they need to inform the provider, because the contrast is going to have iodine. So that's going to be contraindicated. An electromyography, EMG, can be used to measure the strength of the pelvic floor muscles. Electromyography is actually fairly painful. They don't do this super often, but it might be used at some point to measure the strength of the pelvic floor. We can use ultrasound also to examine the kidneys. Cystoscopy, a surgeon uses a lighted instrument to directly visualize inside the bladder and urethra, the lower part of the urinary tract. It may be done under conscious sedation. So as a nurse, you would be responsible for prepping the patient and then recovering from conscious sedation. Urodynamic testing is testing for bladder muscle function. So that's a specialized type test. So when you are looking at these labs and tests, I want you to go to that Pagana book, and I want you to look up, what is this test actually testing? So for example, what is a creatinine actually measuring? What is creatinine? Where does it come from? How does it show us how healthy the kidneys are? So I want you to begin to understand the specifics about testing. And the place to go for lab and diagnostics is going to be that Pagana lab manual. Okay, when we're talking about meds, your Davis drug guide. And if you want to get more in depth with specific classes of meds, you're going to look at the Key pharmacology book. Not Key anymore, it's McQuestion, the pharmacology book. The final thing in this section is going to be general urinary health measures. People can usually void more easily in the position they're used to using. So if we have a patient that we're trying to get to void, we need to get them into the position they're most comfortable with. That's usually sitting. Most men prefer to void standing in our culture. We need to provide privacy, provide adequate time for voiding. Women should be taught to wipe front to back to prevent moving fecal bacteria up into the urethra. Uncircumcised men should retract the foreskin, clean under it, and replace it daily with a bath. Anytime we move the foreskin, we've got to put it back where it belongs, or we can end up with complications. And we should teach people to avoid scented and dyed products, in particular women, because if we have scented feminine products or toilet tissue, things like that, those dyes can cause inflammation. Inflammation is a site for infection. Okay, we're going to talk about incontinence in the next section.